This week I thought I should do a video on one of the most common and complicated pediatric cases that we usually see in the hospital. I will start talking about the history briefly, and then we will just have a short discussion around this patient. Welcome to PaedsCrib, where we guide young minds to heal young lives through case-based discussions. I am Dr. Manyesane, a pediatrician based in East London. If you find value in our content, don't forget to subscribe, like, and share with peers. And make sure you hit the bell notification so you never miss an update. Let's dive in and grow together. The case is a 7-year-old boy who was previously well, who had a history of flu-like symptoms 2 weeks ago, who apparently, according to the mom, fully recovered. Now is coming with a 2-day history of exertional dyspnea and generalized body swelling and loss of appetite. On examination, this child is in obvious respiratory distress, is tachycardic, is tachypneic, he's poorly perfused with capillary refill time of 4 seconds. On cardiovascular examination, he was having weak pulses even though he was tachycardic. Apex was displaced. The child was found to have a paedsystolic murmur in the apical area radiating to the axilla and had a gallop rhythm. On chest examination, on top of the fact that he was obviously distressed, he had bilateral crepitations, and on an abdomen he had a hepatomegaly. So this is the case that we're going to be discussing around today. Now, after this history and physical examination, you make an assessment of dilated cardiomyopathy in congestive cardiac failure and cardiogenic shock. So this is the case we'll be discussing today. Now, there's lots of causes of exertional dyspnea in pediatrics, ranging from respiratory, asthma being number 1 on the list, going all the way to cardiac and some other causes like neuromuscular junction problems. But out of those, there's few that will be associated with a generalized body swelling. And therefore, this would make you put cardiac causes higher up on the list as opposed to the other causes. And also, the history, the 2-week history that this child had a preceding viral infection, like the flu-like symptoms that this child had a week ago, that is a history that is trying to direct you as to what could be possible causing this possible heart problem in this child. And this is a very much typical history of a dilated cardiomyopathy secondary to a viral infection. They usually have a preceding history of a viral infection, and that viral infection causes myocarditis, and therefore 2 weeks later the child will come with cardiomyopathy in congestive cardiac failure. So this is a very important clue for us to keep in mind. And on top of that, the physical examination that you would do on top of this child having signs of cardiac failure, the other clues that might make you think of a dilated cardiomyopathy is the weak pulses. So because they have this weak myocardium, the heart is unable to pump properly, and therefore decreased stroke volume and decreased cardiac output, and therefore decreased blood pressures. They will have very weak pulses and they will have soft heart sounds, and because of the dilation of the ventricles, that will then open up the mitral valve, which will then lead to mitral incompetence, and therefore the paedsystolic murmur that you hear in the mitral area. So this is a very typical history that we must keep in mind when we're dealing with a dilated cardiomyopathy, especially secondary to viral infections in the pediatric population. Now, taking a closer look of the causes of dilated cardiomyopathy in pediatrics, even though most of the time we talk about infections are the most common cause, infections are the most common secondary cause of dilated cardiomyopathy. But it is important to know that primary causes or idiopathic dilated cardiomyopathy is the one that is actually common in the pediatric population. But secondary causes of dilated cardiomyopathy, then infection becomes number 1. So this is a mnemonic that you can use to help you remember some of the causes of dilated cardiomyopathy in pediatrics. So let's now look at shock in this patient and try to figure out what could have caused this shock. So from the first video that I uploaded in this channel where we've discussed a shocked gastro baby, we did conclude that shock is actually defined as tissue hypoxia that causes anaerobic respiration with the release of lactate. And from that previous video, the shock was caused by severe dehydration, which had led to this tissue hypoxia. Now, the cause of shock in this particular patient, the pathophysiology pathophysiology is a bit different from the shock that had happened there. And we concluded in the previous video saying that was called a hypovolemic shock because it was due to dehydration. Now, in this case, the tissue hypoxia causing anaerobic respiration with the release of lactate and the fact that the child is poorly perfused with a capillary refill time of 4 seconds is caused by a different kind of shock, which we called a cardiogenic shock. So the cardiac, the heart, is the problem that causes this kind of tissue hypoxia. So in this patient, we have a weak muscle that is unable to pump out blood properly. So in this case, we will have a decreased cardiac output. And if we have a decreased cardiac output, it means therefore we will have decreased blood going into the tissues for perfusion. And if there's decreased blood going to the tissues for perfusion, because oxygen is carried through blood, it therefore means there will be decreased oxygen reaching the tissue level, and therefore there will be tissue hypoxia, which will lead to anaerobic respiration and the release of lactate. So the cause of this kind of shock in this patient becomes very important because the way you are going to manage this particular shock is different from the way we had managed hypovolemic shock, which was caused by dehydration, because in that particular case we needed to give fluid. But in this particular case, because the problem is the cardiac and this patient is fluid overloaded already, it means the way we're gonna need to manage this kind of a shock is gonna be totally different. So please stay with me as I take you through the management of this patient. Now, the way we manage a patient with congestive cardiac failure in pediatric population, we look at what we're trying to target, look at your pathophysiology and figure out what are you trying to correct. For example, in this case, we have an ejection problem. The heart is unable to pump out properly to give enough cardiac output. So we have a systolic or an ejection problem. So there are 3 things that you look at targeting when you managing a patient who is in congestive cardiac failure. Are you targeting the preload? Do you have a problem with the preload, which is the amount of blood returning to the right side of the heart from the systemic circulation? 2, are you targeting contractility? Does this heart have a problem with contractility? And 3, are you targeting the afterload, which is the pressure that the left ventricle has to exert to pump blood into the systemic circulation? For example, in this patient, we would want to target preload first because there is no problem with the venous return. Blood is coming through the right side of the heart, but now the problem is the left ventricle being able to eject all that blood that is coming back. So it means we're going to have a problem if the left ventricle is unable to eject all the blood that it's receiving. So it means we do need to decrease our preload a bit. How do we do this? By diuresing the child. So we give diuretics. Secondly, we have a problem with contractility, which gives us the systolic problem or the ejection problem. So meaning that this is a very important step in this patient because this is a step which will determine as whether you will be able to take this patient out of the shock that the patient is. It means for you to take the patient out of the cardiogenic shock, you need to improve the contractility of this heart. So the way we do that, we give drugs that are called inotropes. They can be oral, they can be IV. Your oral form being the digoxin and your IV forms being things like dobutamine. So it means you need to contract this heart, and by contracting this heart, it means you are generating enough cardiac output for tissue perfusion, and therefore you are improving that tissue hypoxia. Then the last thing is you would also want to improve the afterload in this patient. You want to make it easy for the left ventricle because it's failing already. Therefore, make it easy for it to pump blood into the systemic circulation. This is by giving things like beta blockers. Slowing down your heart rate a bit will allow enough time for the left ventricle to fill during diastole. And if it fills properly, it means it will therefore eject properly, eject enough cardiac output for tissue perfusion. And other things that you can do, like use things like ACE inhibitors. So you cause vasodilation at the peripheral level to make it easy for the heart to pump blood into the systemic circulation. So ACE inhibitors have been found to decrease morbidity and mortality in these patients, especially things like carvedilol if you do have one. So it makes it easy for the heart to pump blood into the systemic circulation. So this is how you would take this particular patient out of congestive cardiac failure, and this is how you would take the patient out of the shock that he's in by improving the contractility and improving the tissue perfusion. I hope it makes sense.